Good to see so many familiar faces today, and this is a lecture I built this year because I think part of this is, in clinic, when you first come to clinic and you see the rheumatologist, there's a lot of things to do, right? You've got to get your CT scan, you've got to get your pulmonary, you've got to talk about clinical trials and this and that, and often, the visits, there's just not enough time in a single visit to talk about everything we need to talk about. And for medical students, we have a whole, Northwestern is a whole curriculum that goes on for, I think it's 2 years, of medical decision making, right? Like, how do we decide when to use certain medications or when not? How do we assess risk? So we, as students, you do this for a year to kind of understand how to use these medications. And as a patient who may not be on a lot of medications coming in, all of a sudden scleroderma diagnosis and these things get thrown at you, right? And now all of a sudden you're looking at the packaging or listening to the commercial and oh my God, why would I take this, right? And it gets really overwhelming sometimes. And sometimes, it even leads to people stopping medications, because they're like, oh my God, I saw the package insert and, I don't want this side effect. And I can totally understand that. It is, I think there's a lot of information out there, and it's really hard to sort out what to believe and, what are the risks that you might actually expect and what are these risks that are kind of hypothetical or out there. So that's a large part of what this presentation is about. So I did a small amount of work, consulting work for Cabaletta Bio, which has a CAR T-cell trial that is active now. So that is my only disclosure. And then our objectives are we're going to talk about a framework. So there's always going to be a lot of information. I don't want you to feel like you need to remember everything. It's really going to be about the general concepts, right? A framework for how do I even think about this. And then we're going to introduce some key concepts for how to assess medication risk. And then we will talk about some specific medications that you might encounter. I didn't want to get too much into the details of each individual medication because that gets really dry, and also that may not apply to everybody. But there are some common medications that many of you may be on that we'll just go into briefly. So the first part is going to be like a medical decision-making 101. This is like a mini med school. And that's going to be how do we think about medication risks. And then part 2 is what are the, if we're going into examples of some things that actually many of you will be on, what are some common medications and how can we minimize the risks? Okay, medical decision-making 101. So there is this phenomenon that you should know about. And it's something that we see all the time. It's this medication pendulum, right? So there's often this dramatic shift from when a medication first comes out and they say everybody should be on this, put it in the water, right? Or, like opioids. When I was in medical school, said pain is the 6th vital sign. We're under-treating pain. Pain medications are not addictive. And then lo and behold, 4 years later, it was like you can't prescribe it unless you've got to, have your phone as a second, because I think sometimes we don't realize the risks until medication has been out. And then over time, it settles back out again. So sometimes a new medication on, you think this is the best thing since sliced bread. And then years later, say, oh my God, why are we giving this to everybody? It's too dangerous. And then you pull it back, right? So it's got to be the right medication for the right person. And it's got to be a decision about what are the risks of what you're treating versus the risks of the medication? Can this medication help you live a better life, a longer life? So I think there is, when we think about medications, I see this happening with PPIs now. So things like the antacids, where before it was kind of like, okay, everybody's on these. And then now it's like, oh, they've got side effects, and why are people on this? And so there's a push to take people off. The truth is in the middle. So when we think about risk, there's 2 concepts. There's absolute risk, and then there's relative risk. So the absolute risk is the actual risk. So what is the actual chance that I'm going to get this side effect? Sometimes when we hear things in the news, we're only going to hear that relative risk, right? We might hear, this medication increases the risk of lymphoma by 300%. 300% is 3 times the risk, right? So things like lymphoma, that's a really, really rare event. The risk of lymphoma might be 1 in 10,000. That may still be very, very low. And for a lot of people, a 3 times increased risk may not translate into much of an increase in risk at all. But obviously something like that is a more serious side effect, and so often more serious side effects, you're going to see that the risk is really rare. This would be in contrast to something that's a more common risk, like infection is pretty common. People get sinus infections, people get respiratory infections, especially in the wintertime. Let's say 10% of people on this medication get a serious infection. Now it really does matter if you double the risk of infection, because now that's 20%. Instead of seeing 1 in 10 people get an infection, now you're having 1 in 5 people get an infection. Okay, here's a visual example of how that difference between absolute and relative risk works. So on the left side, you see something where there's a low baseline risk. So let's say medication A in green doubles your risk of an infection. If the risk is low to start with, you see that doubling the risk doesn't make much of a difference. That risk really is kind of flat. If that risk is already higher to start with, and now you double it, now you're actually getting a meaningful change, right? So, it may be that, in the scenario where the infection risk is low, medication A doesn't make much of a difference at all to most people. But in the situation where that risk is higher to start with, now doubling the risk makes a big difference. Okay, so we talked about absolute versus relative risk. There's also causation versus correlation. And I bring this up because you will, looking online, and I don't discourage, you have to, everybody Googles, right? You have to, I think, and sometimes you learn something by Google. But you will see legitimate medical institutions that have a list of quote-unquote side effects for medications that are just bizarre, right? So these are things that are probably reported in post-marketing data where, the company, they do these surveillance safety data reports and somebody says, I got a cold or something, on a PPI, right? Maybe totally unrelated, but that's submitted as a safety report. And so these are things that are reported in post-marketing. It doesn't mean that these are side effects of the medication. So when you see, and a lot of places will list these as, these are the most common side effects. And you're like, this has nothing to do with that, right? That's not what the medication does. So there's this concept of causation versus correlation, right? So lots of things can happen to people taking medications. Lots of things happen to people in life. But the question is whether the medication is causing that and to what degree. So obviously seeing 2 things, I think most people understand, seeing 2 things that increase together doesn't necessarily mean that one is the cause. And sometimes what we think of as side effects of the medication may be due to the actual condition that, because in post-marketing, you're not necessarily separating out what is the condition versus what is the side effect of the medication. So here's the example of correlation versus causation. Correlation is like a triangle. So for example, let's say that someone's illness is worsening. Somebody has, let's say interstitial lung disease. And they start a medication for their interstitial lung disease like mycophenolate. And now someone has worsening shortness of breath because their lung disease is progressing. Worsening shortness of breath can be reported in post-marketing as a side effect of mycophenolate, even though it is the reason that the mycophenolate was started. Okay, so in that case, both of those things were caused by the same problem. You started mycophenolate because the lung disease was worsening, got shortness of breath because the lung disease was worsening. The causative pathway is a line. So that is where the medical problem is, let's say the medical problem is worsening, so medication is started, and then directly because of the medication, a new side effect occurred. So for example, lung disease was progressing, someone started mycophenolate, they got a serious bacterial infection because of mycophenolate. So it happens. Things that lower the immune system can cause increased risk of infection. That's a direct side effect. Okay, here's a good example of correlation or association. So, and this is true. People who quit smoking are 26% more likely to die of lung disease in the following 5 years after quitting smoking compared to people who continue smoking. So that is a great example. We always recommend quitting smoking, right? So that is, they're biologically, absolutely, you should quit smoking if you have lung disease. When people get really sick with lung disease, they may be hospitalized, and they can't smoke when they're in the hospital. Or they may be too sick, and those cigarettes don't taste good anymore. So sometimes people quit smoking because their respiratory disease is worsening. And they also, the respiratory disease is worsening, and that can increase the risk of dying, right? So quitting smoking does not cause you to die. It is one of those things where it happens if people are feeling sick already, that they may no longer want to smoke. So it's a great example of why you can't always say, this is just because quitting smoking increases your risk, or there's an increased risk associated. See, I switched back, but there was an increased risk associated with quitting smoking. Yes, absolutely, you should quit smoking. It's good for your body. That's just a correlation or an association. So how do we know whether a medication truly causes a side effect? So really, really important. Randomized, placebo-controlled trials. It's really, really hard. I think nowadays, it is, the placebo arm is really important, and we'll talk about what a placebo does and why that placebo is really important. But you have to compare against something that's like it, right? So if you don't have a comparison group, you don't really know what is what, or what is a side effect of the medication. So if you want to look at side effects of the medication, it's often really helpful to go back and actually look at the tables in that placebo-controlled trial and see what were the most common side effects in that trial and how common were they when someone took a sugar pill. And that can often tell you, to what degree that medication will change the risk of a certain side effect. It's really important that there be a biological rationale for the side effect. So if there's no biological way that I could explain why a medication might cause something, then it makes it less likely that that could be so, right? So there needs to be a rational answer, not just these two things go together, but there needs to be kind of a pathway that can happen. So dose dependence it can be really helpful in a scientific way to figure out whether something is actually causative or not. So for example, if we take, antacids and PPIs and kidney disease, we would want to see if, antacids or PPIs cause more kidney disease. We would want to see that people who took those for 20 years every single day had a greater risk than people who took it for 1 year, right? So there's a dose dependence, right? The more medication you're on, the more likely this is to occur. That's a good indicator of whether something's causative. And then temporal association. This is really helpful for an individual if they want to know, is this a side effect? Because, let's say you started, medication in September and your kids went back to school and, all of a sudden you were sick with a sinus infection, right? Is that from the medication starting that you were sick with that sinus infection? Is it from your kids going back to school? So sometimes what you do is, in collaboration with your rheumatologist, you take a break on the medication, and then maybe you restart it at another time. If you get sick again with that sinus infection, well, maybe it is, right? So it is, and that goes into that strong, consistent, or specific association, right? So it started, the side effect had to have started after you started the medication, and it should recur if you try it again. Now, that's not always possible with everything, but for an individual, that can sometimes be helpful, is kind of take a holiday on the medication and then restart it and see, for you, is this a side effect? And there's lots of things that are written as side effects. There's sometimes things that people report that probably are side effects, but are just not reported. So it is possible. It's possible that people can have an unusual side effect that is not reported. Okay, the placebo effect. We talked about the importance of the placebo and why we do those randomized placebo-controlled trials. So the placebo effect is real. So the placebo effect is phenomenal. So, when we did our study looking at scleroderma in mice, we actually, it was really important. We actually looked and we did injections into the mouse skin, but we also just stuck a needle in the mouse skin. And there's really important biological changes that happen when you stick a needle in something. Or when you give somebody a pill, pills too, even placebo pills or sugar pills, not really sugar anymore, they contain compounds, they contain chemicals. And there was one study that showed that people had a lot of GI side effects from the placebo because the placebo contained a compound that caused GI side effects. So it is, the placebo effect is really real. You can see biological changes and even things like lung disease that you wouldn't expect to have a placebo effect, they do. Placebos actually can be beneficial on your pulmonary function tests. And even if you know about them, the placebo effect it's less if you know about the placebo effect than if you don't, but it still works even if you know about the placebo effect. So when the placebo is more invasive or more expensive, the placebo works better. And this is especially shown in studies involving pain. So if you do sham surgery, which is a much more invasive intervention than a pill, sham surgery has a tremendous placebo effect. And injections have more placebo effect than pills. And if the placebo is given in an environment that's kind of high tech or more state of the art, you actually get a more placebo effect. So these are known phenomena. The placebo effect, I think, can be helpful, right? So it is something, harness that placebo effect. It is, if something's harmless but is a placebo and it helps your pain, it's great, right? There's a biological effect to that. This would be, a graphical example of that placebo effect. Now, we see the placebo effect a lot in Raynaud's medications, and that's why part of why it's been so hard to study Raynaud's is because there's a really strong placebo effect to Raynaud's. And so this is kind of similar to the data that we saw from Botox versus sham injections. So medication A in green, again, you can see if you saw that curve in green, that would look great. Those Raynaud's episodes are decreasing over time with medication A, but when you compare it to a placebo, it looks about the same, right? So it's not to say that it's not doing something or that it's not helping you. It is, but a lot of the effect is probably through the placebo effect. So where can you get good information? So your rheumatologist, obviously, assuming that your rheumatologist knows about scleroderma and the specific effects that people with scleroderma can experience. And sometimes the effects that people with scleroderma experience are going to be unique. These medications that you're on can also be used for other conditions, like mycophenolate can be used for transplant. And you're going to see different side effects in people with scleroderma who have a lot of GI disease versus people on them for a different reason who may not have the same things that someone with scleroderma does. So patient education materials from reputable organizations like the Scleroderma Foundation of Greater Chicago, the National Scleroderma Foundation, so all these places that, the Arthritis Foundation that put out patient education materials or kind of webinars, randomized placebo-controlled trials, you can. Now, if you have insomnia, reading a clinical trial is a good way to cure yourself. So you don't always need to read the full text, sometimes just the tables. The tables, you can kind of look and see, what happened in this group versus what happened in this group, and they can be really informative. Okay, so key concepts. It's really important to know how common a side effect is, so that absolute versus relative risk. And then correlation and causation are not the same. So you have to think about, whether this is really causative. And you can ask your doctor, right? Because I think, there are certain things that we'll talk about, probably are on the causative pathway and certain things that are not. Okay, so common medication side effects and how to reduce risk. Okay, this was from my garden 2 years ago, which looked a lot better. This year was not a good year, so these are old pictures, but it's, so general strategies to grow your health garden. So, we always want to know, what can we do that's not medication? Because you should do everything that you can that's not medication. And scleroderma, it's a powerful disease. It's something that most people are going to need some sort of medication. But the more things that you can do, the better. Exercise. Now, this does not need to be marathons. Marathons actually may have a pro-inflammatory effect. So the sweet spot is really 30 to 45 minutes of moderate intensity activity about 5 days a week. So this is like a walk, and, get your walk, get a little fresh air, enjoy, the sunshine, breathe only clean air. there's a lot of people with marijuana. I'm not, opposed to that in combination with your doctor, but don't smoke it, please. No smokes, no vapes. So, everything going into your lungs should be as clean as possible. Even things like candles, gas stoves and things like that actually can have a negative impact on the lung function. So it's just something to keep in mind, if you have, if you like to cook on a gas range, which we do, make sure you have a good ventilation hood. Maintain a healthy weight, and that's different for everybody. It does not need to be this normal BMI, 18 to 25. There's a little bit of, controversy about it. It is your healthy weight. You can ask your doctor, but it's really about what's healthy for you. If, the weight that you're at, you feel good, you have energy, your joints feel good, that may be your healthy weight. Reduce stress. I don't want you to stress about stress. That's the worst kind of thing, because then now you're adding stress on top of it. Everybody has stress, that's life. But, things that you can do, some people do this Calm app, they meditate. Actually, when you meditate, it can stimulate the vagus nerve, which may have some kind of anti-inflammatory benefits in autoimmune disease. So, and even things like mindfulness, right, of just, looking out your window and watching the birds for 10 minutes, that's mindfulness, right? That's paying attention to your surroundings, paying attention to your environment, kind of getting out of, that stressed out headspace can be helpful. And then there's different diets out there. A lot of people, kind of believe in these autoimmune protocol diets. I think the Mediterranean diet is really tried and true. It really, kind of plant-based, olive oil, avocados, whole grains, mixing up your grains, quinoa, chickpeas, the Mediterranean diet has been shown over and over again to have lots of health benefits. So having a healthy diet, and I'm not saying that you should, change your diet dramatically. You want to enjoy parties and enjoy life with your friends and family. And socialization is part of reducing stress. And so, you don't want, the diet to be interfering with your ability to live, a fun and happy life. But, moving to a little bit more kind of plant-based can be helpful. It can be helpful for the gut. It may help the gut microbiome. So all these things, it's not just one thing, but all these things together can help improve your brain function. Exercise, I think we forget, is a really, really important strategy for helping your brain function. Dance, especially, just putting on music and moving your body actually has some specific brain health benefits. So yeah, put on some music, just groove in your chair, or whatever you want to do. And some of these medications can affect your bone and muscle health. So can scleroderma. And so you want to do that exercise to help improve the bone and muscle health. Exercise can also help you reduce your infection risk. So exercise has a mild immunomodulatory effect. So it actually calms down the immune system to some degree without increasing your risk of infection. That's brilliant, right? So, add that into your, medication program. A little bit of exercise can sometimes help give you a little boost. And then obviously, scleroderma, having chronic inflammatory disease, you have to be mindful of your cardiovascular health. And all these things can help improve your cardiovascular health. Okay, so the categories of the scleroderma medications that we're going to look at would be the proton pump inhibitors, the Raynaud's medications, the nonsteroidal anti-inflammatory drugs, corticosteroids, and then disease-modifying anti-rheumatic drugs. And we'll spend a little bit more time and some specific categories within there. Again, a lot of stuff. I don't want you to feel overwhelmed by a lot of these things are kind of so that, like, if you go on something, not everybody's going to be on everything, but it may be something that you look at this and, oh, this rings a bell, or I should ask about this. And when you're talking about your doctor about that, I would say that the way that I would think about that conversation, if you're starting a new medication, I would think about, what are the most common side effects of this medication? You might want to hear about all those rare things, and often those rare things are the most serious types of side effects, which is important to ask about. But to me, I would want to know, what's likely to happen, right? What should I look out for, and what's realistic? And then how do you monitor for side effects? Am I going to need labs? Are we going to do check-ins? Do you want me to email you? Would you want me to call the nurse? And if I stop the medication because of a side effect, will the side effect go away? And I think this is a really important one because, sometimes, again, we get really overwhelmed by, into, this whole packaging list. But a lot of things are things that there are side effects as long as you're on them, right? And so, sometimes we don't know what side effects someone's going to have until they take it. And if you stop it and it goes away, that's a different risk calculation versus something that would be permanent. And a lot of times when we're talking about pills, a lot of the side effects would be temporary, right? If you have a side effect, you can stop it or change to different medication. And then what can we do to minimize risk, which is what we're going to talk about here. Okay, so proton pump inhibitors. These are those antacid medications. I would say this would probably be one of the most common medications that people with scleroderma will be on. So they have different names. There's omeprazole, esomeprazole, lansoprazole, dexlansoprazole, pantoprazole, rabeprazole. They have brand names as well. So you've got to look at the package because if you're buying it over the counter, they may have different names. So they have lots of potential benefits. So heartburn is a major, major issue in people with scleroderma. And I would like to emphasize this because, it's true, there's been overprescribing of PPIs, so there's a lot of people in, primary care practices that are just on a PPI for no reason at all, right? Or maybe a kind of a soft reason. Scleroderma, the acid reflux is no joke. Acid reflux due to scleroderma, there are some studies suggesting that it can potentially damage the lungs if you breathe it in. There's definite risk. There's, some people with severe acid reflux, they get so much inflammation in the esophagus that they have a difficult time swallowing. Food sticks in the chest. And then, it's like if you ever ate a chip the wrong way and the chip is stuck here, that's what it's like eating anything. And that's, sometimes that can lead to people going in and having to get a scope and having someone open it up. So the consequences of acid reflux are much more profound in people with scleroderma than, the average person who has kind of the run-of-the-mill reflux from, eating chili or something. So reducing heartburn symptoms is a big deal. We don't like people having persistent heartburn symptoms with scleroderma. And some people with scleroderma can have a lot of heartburn but not have a lot of symptoms. And that is something we don't quite understand, right? Some people who have really severe heartburn, they don't feel it. The reflux goes in and it damages the esophagus and they feel nothing. And that's a little scary too sometimes because then sometimes symptoms aren't enough to tell you whether or not you're getting damage. So cough can be a symptom of heartburn or of acid reflux in scleroderma. So, you're waking up, you feel that sore throat, feel that cough, like a dry cough, that often is heartburn. And so some people will use it to treat that. There's a condition called Barrett's esophagus that can lead to esophageal cancer. And in that case, the gastroenterologists are very, very strict about controlling that acid to prevent the precancerous changes from turning into cancer. And then I think the lung damage is, that's actually one of the studies we're doing in the CONQUER registry. So the CONQUER registry is a very large registry of people with early scleroderma. We enroll at our site. It's multi-center. And this is the advantage of being in things like CONQUER is we can look at things like this. So one of our questions that we have a study with Alana Bernstein at NYU, and one of our studies is asking if you're on if you have acid reflux and more severe acid reflux, is that associated with more lung damage? And does being on an antacid, like a omeprazole or one of these PPIs, actually reduce that risk of progression if you have severe acid reflux? So that's a question that has not been answered, and we're hoping to answer from that CONQUER registry because a lot of people do actually prescribe it because someone has lung disease. And we don't know whether that may be true, that may be helpful, it may not, but we're hoping to find out. So side effects, these are real. I think the decreased bone density issue is real. So antacids, the PPIs can reduce your absorption of certain vitamins and minerals. And so there is an association between the PPIs and osteoporosis, and I think it probably is true side effect. There can be an increased risk, and it's a dose-dependent risk, so I think it's real. There are proton pump inhibitors. There are proton pumps in the kidney. So in theory, biological rationale, proton pump inhibitors may affect the kidneys as well. And you can see it's not generally something where you would see a sudden rise in, or sudden decline in the kidney function or rise in the creatinine. But it is something that, in somebody whose kidney function is gradually worsening over time, sometimes you do have to think about this as a potential contributor to it. There is a possible increased risk of dementia with these. This has been all over the news. Now, there are actual studies showing that acid reflux is associated with dementia. Again, correlation. These are not, just because acid reflux does not cause dementia. And maybe people who are having cognitive issues maybe get some reflux or maybe get prescribed these. But one of the ways that the antacids may actually affect that risk is through decreased absorption of vitamin B12. So there may be something real to that. And then increased risk of GI infections. We don't see this a lot, but there are some studies showing that if your stomach acid is less acidic, it may be not as good at killing bacteria. So how do you minimize the risks? So bone density scan. I think we talked about last year with calcinosis, people with scleroderma are at increased risk of osteoporosis just by having scleroderma. So bone density scans are indicated for people who are postmenopausal. Talk to your primary care or your rheumatologist. Or if there's certain other conditions, like if you're on chronic steroids, could you get a bone density just by having scleroderma alone? The insurance companies probably will disagree with you on that. But or just by being on a PPI, will they allow you to have a bone density scan? That's a great question. Insurance companies are kind of slow to understand, how these slow to change their practices. But definitely if you're eligible for a bone density scan, you should get the bone density scan and then be treated appropriately based on what that shows. Exercise, 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 and it doesn't need to be, we talk about weight bearing. Weight bearing is walking, so that's your own body weight. So anything that jostles your bones is going to help with bone density. So exercise to improve your bone health and your brain health too. And then we often recommend 3 servings of calcium-rich foods daily. Now, if you're having GI issues or you have, dairy intolerance, dairy-free milks are a great alternative way to get calcium. In general, ask your doctor about if you need any supplements if you're not getting your 3 servings. We don't want to over-supplement with calcium because it can cause constipation and it may increase calcification in the blood vessels. But try to be mindful of getting your nutrients for your bone health. I have been checking B12 levels more recently since the neurological data came out, and we do actually see quite a bit of B12 deficiency in people with scleroderma in general. But every once in a while get your B12 level checked and just make sure that your B12 level is good. Sometimes just adding more B12 by mouth actually will help you get more absorption. Not everybody needs B12 injections. And then check your kidney function periodically. In general, people coming to our clinic are often getting labs at least once or twice a year, which is a good program. It is, PPIs, if we see changes in the kidney function, they often happen very gradually. And I think question mark about H2 blockers like Pepcid, there is a push now to kind of people coming off of the PPIs and going on Pepcid, which is an H2 blocker. It may ultimately, talk about the medication pendulum, it may ultimately be found to have similar long-term side effects as the PPIs, just because the way it works is very somewhat similar. But it is always something, if your acid reflux is well controlled and GI thinks things are looking good, and you can reduce the dose, why not? The less exposure you get to medication, as long as your symptoms are controlled, less exposure is the better. Raynaud's medications, again, another common class of medications. So examples would be the calcium channel blockers. So amlodipine and nifedipine would be the most common. I usually don't prescribe diltiazem for Raynaud's. There are some cardiologists that do prescribe this. They're not shown to be as helpful as the amlodipine and nifedipine, but some people do find benefit from diltiazem. And then sildenafil, which is the generic name, the brand name would be Viagra. Tadalafil, the brand name there for a certain dose would be Cialis. And then losartan sometimes for people who can't tolerate amlodipine or nifedipine. So they can improve Raynaud symptoms. Obviously, if you're having finger ulcers, really, really important. Often in those cases, we're going to sildenafil or tadalafil. They can, if you have high blood pressure, that's a nice side effect. So sometimes there are good side effects. And if you have high blood pressure and you go on one of these medications, 2 birds, right? And then, same thing, people with AFib, might be on diltiazem. It can slow the heart rate, and that might be a nice side effect. So headache and leg swelling, very, very common with amlodipine and nifedipine. Not so much with sildenafil, tadalafil, and losartan. And so it's just something to think about if you're having real, and the leg swelling can even happen years after being on these. Sometimes it can be profound. So again, if you're having that, report that to your doctor, and maybe something to ask about. Just as people with high blood pressure, it might be nice to have some blood pressure lowering. The blood pressure can go too low. Amlodipine in nifedipine can have more of that, the blood pressure lowering effect than sildenafil and tadalafil. Same thing, losartan can have more blood pressure lowering effect. There can be worsening acid reflux with some of these calcium channel blockers. So they can relax smooth muscle, which is part of how they work. But in the esophagus, where there's smooth muscle that's trying to keep the reflux from coming up, if you relax that, sometimes you can get a little bit worsening acid reflux. Color vision, so there is a side effect of blue change in color vision with sildenafil and tadalafil. It does not happen that often, and it is, the ophthalmologists are okay with the side effect. They, if it's not bothersome, they let some people continue, but it can happen, and it's, it's supposed to be reversible when you come off of it. And then high potassium can happen with losartan. Okay, so everybody with scleroderma should get a blood pressure cuff. That is, at the first time you get a diagnosis, I think probably more Americans should have a blood pressure cuff because, high blood pressure is the silent killer, and, you want to know what your blood pressure is. You're not always going to feel it. But definitely, you should have a blood pressure cuff at home, know how to use it. Omron cuff, I have no, investment in that brand, but it's a good brand, OMRON. And if your blood pressure is low or if you're lightheaded, call your doctor and ask for instructions on the medications because you may need to change the dose. So for leg swelling, compression stockings can be really helpful. They can be hard to get on. Amazon makes really cute pairs. They don't have to be that 30 millimeters where it's like impossible to pull on. Sometimes 10 or 20 millimeters of mercury is okay. So see what works for you. And if your Raynaud symptoms are well controlled, you may want to stop or reduce. Now, again, talk to your doctor about this, but sometimes people come off of it from May through October, and they go back on October through April. That is, a lot of people have success with that of, if you live in a temperate climate like this and the winters are harsh and the summers are hot, maybe you can take a break. Or if you snowbird somewhere, maybe you can kind of take a break when you're in Florida. Maximize your non-medication hand warming measures. So everybody should have some external heat source if they have Raynaud's. So whether that's the heat packs or rechargeable, USB rechargeable hand warmers, the heated pouch. There's a heated pouch on Amazon that's like $40. It's lovely. It's like it's really lightweight. You can put it over your neck. You can charge your phone in it. And then, obviously if you're on losartan specifically, make sure you got a chemistry panel. So non-steroidal anti-inflammatory drugs, I think people are more familiar with these. I won't spend too much time on these ones, but these are your ibuprofen, your so Advil, Aleve, diclofenac. These are the ones that I'm specifically referring to as being by mouth. And then aspirin is a little bit unique. Often people are on aspirin because they have AFib or they have some other reason to be on an aspirin. They can reduce joint pain and swelling. They truly are anti-inflammatory. It can help reduce some kinds of joint damage, actually. But, again, these are over-the-counter, and we're all very familiar. I took some ibuprofen, last night and today for, a headache. And it's, we know these side effects, right? Like this list is scary: kidney damage, liver damage, gastritis, elevated blood pressure, fluid retention. So they have legitimate side effects, and it's something, especially if there's GI issues happening, you have to be careful about. You want to ask your doctor before taking some of these over-the-counter medications. Like if you have existing kidney issues, usually we'll try to avoid completely. It's just something to be aware of, that even though these are, easy to buy from the drugstore and pop a pill, they're not totally benign. And then obviously aspirin, bleeding risk can be a major concern there. So non-medication pain relief methods can be helpful. Physical therapy, assistive devices. Some people like Epsom salt baths, magnesium salts, relax the muscles. Diclofenac gel, topical diclofenac, is only absorbed about 6%. So usually, the kidney doctors are pretty comfortable, GI doctors are pretty comfortable with topical diclofenac because the absorption is so minimal. And it actually can be really helpful for the fingers and for the knees if you have arthritis there. Check your kidney and liver function periodically. Take it with a good meal. So sometimes if you only eat one meal a day, maybe you need a once a day. non-steroidal anti-inflammatory. And then again, these are as-needed medications, so you don't necessarily want to take it every day if you don't need it. Steroids. So I will mention there are guidelines that came out from the lung doctors and from the rheumatologists in 2023 on scleroderma lung disease, and there is a pretty strong recommendation not to use steroids in people with scleroderma who have lung disease. There's lots of risks of steroids in people with scleroderma in particular. There's lots of names for steroids. Most common would be prednisone, methylprednisolone. Sometimes we use short-term, steroid kind of doses for the shortest period of time. But these are pretty risky to be on long-term. You have to, again, we talked about that blood pressure cuff. One of the most serious side effects of being on prednisone, especially doses 10 milligrams or more for a prolonged period of time, is an increased risk of something called renal crisis. Renal crisis most often happens in people who have been newly diagnosed and who have lots of skin thickening, lots of skin tightness. And so we really do try to get that steroid dose down or off, if at all possible, in people who are newly diagnosed. An occasional, kind of short course of steroids, sometimes we do use for certain issues. But if you're on steroids for long term, and some people do need to be, it happens, right? Sometimes people have more than one autoimmune condition. Sometimes people have asthma. There can be many reasons you might need a steroid. But get that blood pressure cuff and make sure your blood pressure is staying stable on it. And if it's not, you need to tell your doctor. But we talked about scleroderma already lowers your bone density. They can increase your risk of osteoporosis, diabetes, which can be permanent sometimes, cataracts, loss of muscle mass, infection, increased body fat, lots and lots of risks of steroids. I'm not saying, for some people, you may need, again, the right medication for the right person, but there's so many side effects. And so one of the reasons that we're going to get into the next slide of something called steroid-sparing medications, or DMARDs, is because of all these risks of steroids. Obviously when you're on the steroids, if you are, monitor your blood pressure, weight, blood sugar, get your bones checked, get your eyes checked. You might need an antibiotic to prevent infection, and just make sure you're using the lowest dose for the shortest period of time. But these are big. This next slide, the disease-modifying anti-rheumatic drugs, sometimes you'll see your rheumatologist slip up and call them DMARDs, and you're like, what's a DMARD? This is what a DMARD is. So it stands for disease-modifying anti-rheumatic drugs. And these basically are steroid replacements. They're long-term. And so examples would be methotrexate, mycophenolate, azathioprine, tocilizumab, rituximab, hydroxychloroquine. They can be pills. They can be injections, they can be infusions, they can be what we call biologic medications, which are specialty medications that are protein-based, very targeted, or they can be the pills, which are often more broad. And really, one of the main goals is to reduce inflammation without steroids. And so they can reduce inflammation in the joints, in the skin, in the lungs, and different ones will do different things. So some may be better for the skin, and some may be better for the joints, or some may be better for the lungs, but they not good for the joints. So increased risk of infection is an effect of most of these. Hydroxychloroquine would be an exception. They can cause elevated liver enzymes. That's a pretty common side effect of a lot of disease-modifying medications. Often you can detect this, and then if you adjust the dose or you stop, it will often get better. And then lung toxicity is rare, but it's a rare side effect specifically of methotrexate. Cancer is a class effect of most of these, or it's a concern with most things that lower the immune system. So, almost all medications that lower the immune system will carry a risk of cancer. Our immune systems are important for protecting us against cancer. So if you lower them, which you need to do when people have an autoimmune disease, there can be a side effect of potentially you might be lowering your immune defenses against things like cancer. And then there can be certain GI complications with some of these medications. So mycophenolate, very, very common in our centers and many others in the United States. Most common side effect would be stomach upset or diarrhea. Now, white blood cell counts can go low with these. Anemia is a rare side, but occasionally we do see cases where it's just anemia, and the anemia can be really severe. There can cause something called pure red cell aplasia. I don't see it very commonly, but sometimes if someone has a really, really low red blood cell count and there's no bleeding, sometimes you have to think about the mycophenolate. Infection is a definite concern with mycophenolate, as with many others. Mycophenolate colitis is a rare risk. About 4% of people can experience this. It often it can occur years after starting, where you felt fine on mycophenolate, and then years later or months later, it can be cramping, diarrhea, weight loss. So it's something, usually your GI should be thinking about this, but sometimes you may need to remind them, because sometimes even GI doctors, if they don't take care of a lot of people on mycophenolate, they may forget about mycophenolate colitis. And then increased risk of non-melanoma skin cancer. So we always recommend, immunosuppressive medications. If you get an infection, you stop and you call your doctor. You get your labs every 3 months. And if you have GI issues, major GI issues when you're on mycophenolate, even if it's not right when you started, you need to call your doctor. You take it with food, and then especially if you had blistering sunburns as a kid, it's a good idea, or if you have a lot of moles, it's a good idea to get checked by a dermatologist. So methotrexate. Methotrexate can be used for some people with joint problems in scleroderma. It can have some benefits for some people with skin or joint issues. It can cause lung toxicity. There's a rare risk of lung fibrosis. The estimates of this vary. Some estimates go up to as much as 10% of people on methotrexate. And they can cause liver enzyme elevations, very common, especially when combined with alcohol or when combined with ibuprofen. Can cause low white blood cell count. And fatigue is very common. Usually this is the day after you take methotrexate. The fatigue lasts usually for about 12 to 24 hours. And hair loss is also pretty common. About 10 to 15% of people with it get hair loss. It's usually not complete hair loss, but it can be noticeable thinning, and then obviously infection. Methotrexate needs to be given with folic acid. You take folic acid every day. Get your labs. Same thing as mycophenolate. We check every 3 months for most of our medications. And then talk to your doctor about alcohol. In Europe, they will say Europe is much more liberal about alcohol and methotrexate. In Europe, they say you can have 2 drinks a day. And most Americans are kind of a little bit more wary, and we don't recommend regular drinking when you're on methotrexate. But it's something, if you go to a wedding and you have a glass of champagne, usually it's not an issue. It's more of an issue if there's everyday drinking. And because of that fatigue, a lot of people are resting on the weekends. So you might want to take it on Friday or Saturday night and take it with food so your stomach doesn't get upset. There's an injectable form if needed. And if your lung disease is worsening, we as a practice usually switch people to another medication if their lung disease worsens or develops. Tocilizumab, it's an injection. Its brand name is Actemra. It is one of 2 medications that is FDA approved for scleroderma, and it's approved for scleroderma lung disease. Both of the medications that are approved for scleroderma are for lung disease. It can cause low white blood cell counts. This is a common theme, right? Methotrexate, mycophenolate, tocilizumab, they can all do this. It can cause low platelets. That's a direct effect of the medication. Platelets rise with inflammation. When you lower the inflammation with tocilizumab, they drop. Liver enzymes can be elevated, same thing as methotrexate. Okay. Elevated cholesterol is a unique risk, so often the LDL will go up a little bit when you're on Actemra. And because of that, we think there may be a long-term cardiovascular risk. And there is a rare risk if you get diverticulitis or colitis on this medication, that there can be an increased risk of the bowel failing to heal and someone getting a perforation. So again, all right medication for the right patient, you have to use it, but these are things that we do keep in mind. If someone has a history of diverticulitis, we generally try to avoid using this medication if possible. So, and if you get colitis, but it's a one-time event and it's over, we often will consider using it again. Okay, so, but tell your doctor if you have any chronic inflammatory bowel condition. Get your labs every 3 months. If you have abdominal pain or signs of diverticulitis, tell your doctor. If you get infection, of course, let us know. And then we do check fasting cholesterol before and after. Okay, Rituximab, I know some of you are on Rituximab, or not you, but some people with scleroderma. It is one of the medications that in our guidelines for lung disease management, it's one of the options. It's not FDA approved for scleroderma, but there is good trial data. So this one is a long-term immunosuppressant. You can see effects of Rituximab on the immune system even years later. And sometimes people develop a condition called common variable immunodeficiency, which is when they have a chronic low immune system, and that can be secondary to the medication. There's, again, very, very rare risk of something called PML, which is a fatal neurologic condition. It is something most rheumatologists have never seen a case. That said, you're going to read the warning. There's a warning on it about it. Okay. So rituximab, because it's an immunosuppressant, will impair the vaccine response. So you try to get your vaccines before starting if possible. And if you're on rituximab, ask your doctor about timing of vaccines. And then you have to screen and treat for hepatitis B prior to starting. So even if you were exposed but your immune system cleared it, it could come back on rituximab. So that's part of standard screening. You wouldn't, if you're here, you don't need to remind your doctor. We always do that, but it's a good idea to know about it. Okay, and I'm going to skip vaccines just because there is this. There's a vaccine advisor that you can know about, and you can ask your doctor. Vaccines are really important for preventing complications of immunosuppressive therapy. So, and we do recommend vaccines. We don't recommend live vaccines while you're on. If you need to get like yellow fever vaccine or MMR, you need to ask your doctor what to do with your medications before you get that. But for killed vaccines, we do recommend people get the routine killed vaccines. So ask your doctor, start a conversation. This is kind of, I love that people are taking notes. You have this for reference so that if you need to go back and kind of like think about the framework. But it's really about getting the most out of the medication, how the medications can help you live a better life. Be very careful about steroids and have a wonderful conference. And we have like a few minutes for any questions. Yeah. Snake. So, well, it would depend. It's on Ardenagler asks, what is the placebo for the Raynaud's medications? So the placebo would be the equivalent of whatever you're on. So like, for example, for the Botox study, so Scott Lifshay at Hopkins, he did a Botox study where they Botoxed one hand and then they did saline injections to the other. So you kind of need to do the equivalent where the person getting it wouldn't know which one they're getting because, like if you have a placebo that's a pill, or if you have a medication that's a pill, you need to have a placebo that's a pill. And they should be the same size. And so there's not a lot of placebo-controlled trials. There's like an N of 1 trial. This is getting into the nitty-gritty. But for whatever you're studying, for that Botox study, you have to study injections versus injections. So that was what they did in that study, was they did Botox versus injections of saline.
So are Botox for fingers approved now?
No. So some people are able to get it approved off-label, but it's not an approved indication for it.
And getting Botox versus taking like Sildenafil and Nifedipine. I haven't had a Botox shot in a year and a half, and my fingers so hard are hurting. No ulcers. Do I need to go back and get another Botox?
We can talk about that individually. So, and again, this is, like some of these things too, like even though something may not have shown an effect above a placebo, an individual can still have a benefit from something, right? And so, some people who had a benefit, we can still talk about doing the therapy because there's very few on-label treatments for scleroderma. A lot of what we use is off-label and not necessarily proven in placebo-controlled trials. So it's kind of an individual level decision about, how things impacted an individual person.
I just had a question on the, when you were talking about how, it's dropping out of my mind now. The side effects, the scary things that every time you turn on late night TV, they're trying to tell you everything in the world's going to happen to you if you take this medicine, but it's good for what it's prescribed for, At what point does that correlation or that post-medication rise to a threshold where they might actually do a trial to test it to see if it's an absolute risk, I guess?
Oh, if there's a bad side effect?
Yeah.
Usually they don't. So you don't want to do a trial. Like if you think there's a bad side effect, usually you don't want to test it to see that would be like against a lot of the ethical guidelines of trials to do a trial to see if something bad happens. Often it can lead to something being pulled from the market, temporarily while they reassess the risk. But it's not something, if they think that the risk is real and is probably a direct effect of the medication, they have, often they'll put an extra warning label on it, but they won't retry it for that.
One of the handouts I got from someone throughout the years mentioned fluoxetine for Raynaud.
Good point, yeah. It can be. So fluoxetine, the brand name would be Prozac. It can be used for anxiety or as an antidepressant. For people who have primary Raynaud's where they don't have scleroderma, but the Raynaud's is more induced by anxiety, it can be more helpful. Some people with scleroderma do go on it as well. Sometimes, people do have a benefit, even though it's not really shown to be as helpful in scleroderma.
I just wanted to ask, is there any correlation, or have they found any correlation between methotrexate and lymphoma?
So yeah, there is actually there's a very specific type of lymphoma that can happen in the lungs that often recedes and it's directly caused by methotrexate. It's really, really rare. I've seen one case of it.